of Asian people. I don't know if, I think it's vitamin D deficiency or something like that. High iodine diets.
We missing is over there.
Okay. So that's just my thing. You comment, like you'll begin to see that all the time. Like as far as like what happens, what's the most common exams you do on different ethnic groups. You know, like having a fatty liver. That's more of like, you know, you see a lot of Hispanic people with fatty livers, or you see a lot of fibroids in the uterus on African American women. So you will begin to see those trends as far as like what exams are most common for, you know, different ethnic groups, and also different reasons or different indications for these different exams. You're starting to see what's the most common exams for different ethnic groups. Okay, we're going to talk about lab values and clinical indications of why we're doing these exams. What's the most common reason we're doing thyroid exams or parathyroid exams? Okay, explain the sonographic evaluation of the thyroid gland to include patient prep. There is no patient prep for a thyroid gland, right? I don't have to be NPO to do a thyroid. I can do a thyroid any time of the day. Okay, so no patient prep there. Protocols, we're going to go over that today in lab, and we're going to demonstrate the examination procedure. Guys, please let me know when it's 8 o'clock, because this clock doesn't work, so we can go to the lab, and I want to just use that last 30 minutes to show you how to do a thyroid. I already have the machine on. 6 minutes? Goodness gracious. Okay, so let me just give you these objectives then, all right? So we're going to tell the difference between normal and variant sonographic appearances, all right? We're going to describe the pathology, etiology, clinical signs. Again, that's going to be, you know, Ms. Shepherd. She's familiar with all of these thyroid abnormalities. You guys have those on your sheets right there. So again, when you prepare to study for this class, use that NEC handout that I gave you, okay? When you're getting ready to study for this class, all right? We're going to talk about the parathyroid glands, which are, if they're normal, they won't be visible in ultrasound, okay? The parathyroid glands, if they're normal, they won't be visible on ultrasound. You will not see them unless something is abnormal about them, all right? We're going to describe the parathyroid gland embryology, the surface anatomy, anatomic variants, and common relational landmarks, just like the thyroid, okay? Same deal. Correlate laboratory values again. Alrighty. And we're going to also talk about some abnormalities in the neck, because as you know, if you guys have been seeing thyroids, you also do you also look for lymph nodes, right? Have you guys seen when they're doing thyroids? They also look on the lateral aspect of the neck for lymph nodes. Or you're also doing neck exams for like sublingual that's exactly what it is. The submandibular gland. It happens to develop a lot of abscesses. So you know, you also do neck ultrasounds for those as well. Not to be confused, because sometimes if you don't know where to look for the thyroid, people will be up here looking at the submandibular gland, which actually looks very similar to the thyroid, okay, in appearance. Okay, so make sure you're in the right location, C2, C3, when you're looking for the thyroid gland, okay? Instead of looking for the submandibular gland. We don't point in clinic. All right. So identify the usefulness of diagnostic imaging to differentiate between the hematoma and deep neck space infections. All right, and describe pathology again, normal versus pathological cervical lymph nodes. So I will say this: it's not abnormal to see cervical lymph nodes on a normal person. Okay? You can be perfectly healthy, and you're still going to be able to see what's called the thyroid chain of lymph nodes lateral to the thyroid. Okay? So it's not abnormal. That's why if you see one that's enlarged, you're going to have to measure it. If it's greater than 1.5 to 2 centimeters, then you know that would be 2.5 centimeters, then that would be considered abnormal. All right, but you will be able to see lymph nodes all the time. Get used to seeing them when you're doing your thyroid exam.
I saw some yesterday.
You saw some yesterday, but they big?
They big and they small. They have fat tissue in there, and they complex as well.
Okay.
It's really cool.
Like for instance, when I get sick, I have one that always kind of pops up right here. Like even before I'm sick, I can tell like, man, I may be about to get a little something, because my lymph node right here kind of get bigger, and I can kind of feel it. when it comes. All right. So you guys have this already, chapter outline right here. Again, don't let it overwhelm you. Don't let it overwhelm you because we won't be going in super depth on every single thing. All right. So you see, my section is really short. Pathology of the thyroid is going to be most of what you're going to be talking about. Right? So I would say know those pathologies: hyperthyroidism, hypothyroidism, goiter, Hashimoto's, and I forgot the other one. But Shepard's going to handle you on that. All right. So, so real quick before we go to lab, I won't even start it, but I want to just draw what the thyroid gland looks like. Okay, I want to talk about the surrounding structures. Hey, you hit my light bulb? Talk about the surrounding structures of the thyroid real quick before we go to lab, so you can know these landmarks associated with the thyroid, because we use these landmarks when we're imaging. All right. Okay, guys. So, of course, every time we discuss anatomy, we're always going to talk about it in anatomic. What is that called? Goodness, I gotta get short. We're going to talk about it. Pat, what am I talking about?
Anatomic position.
Anatomic position. There we go. Man, I'm just going crazy today. So, anatomic position is basically you guys looking at me. Just like an ultrasound. Your left side is the patient's right side. Your right side is the patient's left side. Okay. So what I'm going to do, I'm going to draw this thyroid in cross section as a transverse thyroid. So that's going to be an axial slice. Me actually, like if I slice my neck just like this, and we took my head off and looked down, that would be us looking at the thyroid in cross section. So in transverse, the thyroid consists of two lobes. Okay, a right and a left lobe that's joined by an isthmus. Isthmus is the connecting piece to the right and left lobes. The thyroid sits around right anterior to the trachea, wraps around the trachea, and it's anterior to the trachea and the esophagus. All right. So this is what the thyroid looks in cross section. I'm gonna illustrate it for purposes of us understanding it. So this is the thyroid right here. Cross section right there, guys. This is my right lobe. That's my left lobe. And this is my isthmus. So this is going to be actually the first image you're going to image right here. Passing out those protocols for you guys. That's going to be the first image you're going to image right here is this thyroid in cross section, just like this. Okay? You want to see all three parts. You want to see right lobe, left lobe, and isthmus. The isthmus, sometimes it's a really thin structure. Okay, so sometimes it's going to be hard to find. The isthmus is usually near the mid-thyroid. The isthmus is usually not superior or inferior thyroid, usually right at the mid-thyroid. Okay, so if you want to get all those structures, you're going to have to look for, I'll say, about the mid area of the Adam's apple or the thyroid cartilage right here. Okay, or the thyroid cartilage. All right, so this is going to be our first image right here. This is a transverse image of the thyroid. Again, the isthmus, I kind of exaggerate a little bit. It connects the right and left lobes as they wrap around the trachea. Okay. So, if this was an actual person, this is anterior, right? Anterior for my probe, anterior, posterior, wraps around. This will be the trachea right there. Okay, posterior to that, that's my trachea. Posterior to that will be my esophagus. Okay, so right behind that, esophagus is what you guys know, what you use to swallow. Okay, and if the esophagus is like a tube. It can kind of move. It moves up as you swallow. It can it forms to whatever you're eating and whatnot. So again, thyroid is the most anterior structure in the neck. Okay. Then posterior to that, it wraps around the actual trachea. The trachea is like the windpipe. it has like C-shaped rings around the trachea. Okay, and then posterior to that, we have what the esophagus, which is what's used for swallowing. All right, so those are our posterior landmarks. All right, so our lateral landmarks. So this is how you know when you're imaging. Like when you're along, if I can see my medial landmark would be the trachea, right? My medial landmark to the thyroid would be the trachea on each side, right? So my lateral landmark, first thing I'm going to see lateral would be the common carotid artery. All right, so about right here in this section, right there, that's going to be my left CCA and my right CCA. My right and my left common carotid arteries. Those are the lateral borders of the thyroid. When I'm in sagittal, I use this structure right here first because I want to make sure my carotid artery, when I'm in sagittal, meaning that when it's long, it's going to be like a tube, right? Like any other blood vessel. Instead of it being in cross section in the circle, it's going to look like a tube, just like this, right? So I want, when I'm looking at my thyroid in sagittal, I want to elongate my common carotid, and then I want to angle medial to start imaging my thyroid. Okay, and I'll say that again when we get in the lab. Okay, so the medial border of the thyroid is going to be the trachea. The lateral border is going to be the common carotid artery. Okay, lateral to that, guys, is going to be a vein.
So the artery is the one that supplies the blood to the thyroid?
No.
So what is the function of the arteries?
The arteries supply blood to the body. They're taking oxygenated blood to the body. Okay. We're going to talk about the specific thyroid arteries and where those and what arteries supply that thyroid. So
this one's not for the thyroid, the CCA.
No, I'm showing you anatomic landmarks right now. I'm showing you anatomic landmarks right now. When we get on Friday, I'll tell you about the actual arteries that supply blood, because there's 4 arteries that supply blood to the actual thyroid itself. Okay. But I will say this: the carotid artery gives a rise to the artery that does supply blood to the thyroid. Okay, because the common carotid artery, as you get higher, is going to branch into another artery, 2 arteries, and then an artery off one of those arteries is going to supply the thyroid. Okay. So lateral to the CCA, guy, and this is really important because you guys are just now starting to scan, and knowing this anatomy is really important because sometimes when you can go too far, and I don't know if you guys know how to tell the difference between an artery and a vein yet, but a vein is more pliable. It's compressible, right? When I put pressure on the neck, that artery, that vein is going to close. The artery is probably not going to close unless I put a lot of pressure on the neck. Okay, so lateral to my common carotid arteries, and I drew it a little bigger because veins fluctuate in size according to the volume of blood. Okay, but depending on how much blood is in there, they're going to fluctuate in size. Okay, so I'm going to have my jugular veins right here, my internal jugular veins. IJV, right, and internal jugular vein left. Okay. So these 2 structures are lateral to each portion of the thyroid. Okay. So our medial structure that's medial to the thyroid is going to be the trachea. You're going to actually see those C-shaped rings as you're imaging. You won't see the trachea. Why won't you see the trachea, guys? Because it's air, exactly. Ultrasound is not gonna, it can't travel through air, correct? It needs a medium. So when it gets to the air, it's gonna be blacked out. Good job, Mike. So you won't see the actual trachea itself. You're gonna see the rings associated with the border of the trachea. Okay? So that's the medial border. Lateral border is gonna be the common carotid arteries are the lateral border. Lateral to that, you have the jugular veins. Okay? Lateral to those, and you're like, man, there's a lot of stuff in the neck, right? Lateral to those, you have what's called I'm just gonna draw a fake muscle right here. You have what's called your sternocleidomastoid muscles. Okay, so right here. sternocleidomastoid muscles. I'm just gonna call it the SCM, okay? SCM. SCM, left. Sternocleidomastoid, right. SCM. So this muscle is really important when it comes to imaging the thyroid because, you know, a lot of times when you see people doing the thyroid, they like to turn the patient's neck like this, right? Or they'll tell them to turn the patient's neck like this. But when you turn the patient's neck too far, this muscle right here, you can even see it bulging out. This is the sternocleidomastoid muscle. It flexes and it gets hard. So that makes it's gonna make it hard to image that thyroid if you have a person turn their neck too far. Okay, and then you're gonna kind of oblique the shape of the thyroid. So I actually never, I don't want to say ever, but majority of the time I will not have the patient turn their neck like the sternocleidomastoid muscle. Okay, same thing when you're imaging blood vessels, common carotid and jugular veins. You don't want to have the patient flex too much because you put pressure on the vein, it's gonna make it close, right? And you won't be able to image properly. Okay, so my main thing with positioning the thyroid is to get some full extension, so I can get this whole area of the thyroid. You know, because sometimes the thyroid can dip down below the sternum, like I told you guys that is. So always, because I missed the mass there one time. When you miss something, guys, when you make a mistake and you miss pathology, you never make that mistake again. So I'm always gonna share my adventures with you guys at any time I miss something. So I remember one time I missed a huge mass. It was like 5 centimeters. So it was pretty big, you know, and I missed this mass because I've seen the thyroid superior, mid, inferior. I was just doing my protocol. But I didn't angle my transducer inferior past the sternum and able to see it, and it was laying right there, right below the sternum. Luckily, we had the CT scan. I was able to look at the CT scan, and I went back. Then I was able to see it with ultrasound. Okay? So, I'm going to show you also the anterior. Go ahead.
So, if you were doing protocol, how did you, because of the CT scan, but let's say you didn't have a CT scan.
Now I know, I always angle below the sternum every time you're looking at the thyroid. Every time I look at the thyroid, because masses can hang off the lateral borders of that thyroid and hang inferior. Okay. So I'm telling you guys to always look in that area so you don't make the same mistake I did. Okay. So.
810.
Huh?
810.
810. All right. It won't take me. We can do it. You guys are gonna be doing thyroids in 10 minutes. You know, if it's a normal thyroid, bang. All right. So these are our posterior structures, posterior to the thyroid. These are structures lateral to the thyroid. We also have 3 muscles that are anterior to the thyroid. Because I want to get in the lab right now, I'll draw those up here, but we'll talk about those on Friday. Okay. But there are also 3 muscles that are anterior. So you have 3 muscles anterior. Structures posterior are going to be the trachea and esophagus. Structures lateral to are going to be the vessels, common carotid artery, jugular vein, sternocleidomastoid muscle laterally. Okay, so guys, let's mob over here to the lab real quick and bring your protocol sheet that I gave to you guys so you can check out these images. You can see that protocol is pretty short, right? Pretty short protocol. But also I want to give you guys something to practice on while you're in lab, while you're in clinic, if you have any downtime. Okay. And because I wasn't 100%